This conference will now be recorded.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين आमीन। मैं पनाह मांगता हूँ अल्लाह की शैतान मरदूद से। शुरू करता हूँ अल्लाह के पाक नाम से जो बड़ा मेहरबान और नहायत रहम वाला है। तमाम तारीफें अल्लाह के लिए हैं जो सारे जहान का मालिक है। वो बड़ा मेहरबान और नहायत रहम वाला है, क़यामत के दिन का मालिक है। इलाही, हम तेरी ही इबादत करते हैं और तुझ ही से मदद मांगते हैं। हमें सीधा रास्ता दिखा, उन लोगों का रास्ता जिस पे तेरा फजल हुआ, ना कि उन लोगों का जिस पे तेरा गजब हुआ, और ना उन लोगों का जो तेरे रास्ते से भटक गए। इलाही कबूल फरमा। सदक़ल्लाहुल अज़ीम। Now I would like to request some questions for the participants to kindly have a few words so that we can start. Sir. Assalamu alaikum. My name is Dr. Khwaja Khalid Trap and I am Joint Secretary of OSC Lahore. I am also involved in Faculty of Ophthalmology at CPSC. So now the latest move on the college front is that we are introducing the workplace-based assessment, and I am thankful to Professor Hamid, who will be delivering a talk on this topic after these presentations. So I hope that everybody will have a firm grip on the subject, and we will be doing practically this in the future. Okay, thank you very much. Thank you very much, sir. Now we are going to start our scientific session in which we are going to have presentations. There are a total of 6 presentations, and they are a combination of cases from, oculoplasty, ocular tumors, as well as the vitreoretinal disorders. So, without any further delay, I would like to call upon Dr. Faisal Mitru, who is our final year resident, and he's going to present a very rare case of a tumor that is in itself found very rare. Dr. Faisal. Bismillahirrahmanirrahim. Assalamu alaikum to all the respected seniors and their colleagues. Okay, first of all, here's just a small clip to welcome you all. Okay, I'm going to start with my case. Topic of my presentation was very interesting. condition as it was a rare growth of conjunctiva, which was very unusual, and it acts as a masquerade in its findings. So 66 years old male patient, resident of Lahore, uh, presented uh, uh, presented with the complaints of mild itching and redness for approximately 1 year, and conjunctival growth, which was painless and progressively enlarging, with foreign body sensation and discomfort for the last 3 months. Growth was not associated with the fever, diplopia, proptosis, and decreased breathing. So here is a pre-op picture of growth, which shows 15 by 18 of soft mass, which was encroaching the cornea and was found in the right eye in the temporal lumbar area. Patient was diabetic for the last 20 to 25 years, with his last HbA1c of 7.2% with no other significant chronic illness. There was no past surgical history, and there was no significant ocular history or any history of trauma. Patient was just using glasses for far and near for the last 15 years and was comfortable with them. On examination, patient's general physical examination was unremarkable, with no involvement of lymph nodes. On ocular examination, patient's right eye visual acuity was 618 and 69 in the left eye. Uh, Left eye finding examination was totally unremarkable. In right eyelid showed congestion, small papillae, concretions in upper and lower lid palpebral conjunctiva. And in conjunctiva, as I mentioned earlier, that there was a soft fleshy tissue encroaching cornea, which was found in right eye temporal and all of his investigations were normal, including all the baselines, ECG, and chest X-ray. Okay. Regarding the differential diagnosis of this case, we divided it into two categories, benign and the malignant one. In benign differentials, there was squamous papilloma and cystic conjunctival lesion. And in malignant one, there was malignant melanoma, lymphoma, and squamous cell carcinoma and metastasis. Okay, regarding the management of this case, after all the discussions and investigations, it was planned to admit the patient for growth excision, and complete surgical excision was performed in topical mitomycin C with concentration of 0.02% applied to the base of the lesion, and then the lesion was closed with biaxial fixed. And sample was sent for histopathology after labeling and proper marking of the borders. And patient was put on topical mitomycin C with concentration of 0.02% 4 times in a day. Okay, this is the histopathologic review of the patient, which shows tumor size of 2 centimeters, with the peripheral and deep margins were involved with maximum depth of invasion of 4 millimeters, and there was no involvement of lymphovascular and perineural invasion, and there was a histologic type of sebaceous cell carcinoma. In histopathological report, base and margins were found to be involved, and a surprise diagnosis of conjunctival sebaceous cell carcinoma was made. We plan to re-examine the patient to look for any lesion in the lid, and we planned investigations to rule out any metastasis. And topical mitomycin C concentration was increased up to 0.04%. Okay, this is a post-op picture of the patient. Post-operatively, we found that there was a generalized congestion in both upper and lower palpebral conjunctiva, and there was no isolated nodule and any suspected area of malignancy. This upper lid, which was marked inflammation post-operatively. Okay. Patient was also sent to oncologist at Anmol Hospital for further opinion regarding radiotherapy and some other opinions for regarding his treatment. There, his baselines were repeated, including LFT, abdominal ultrasound, and MRI head and neck with IV contrast, and all were normal. Patient was counseled about the prognosis and recurrence of the disease. And oncologist advised to continue the same treatment with topical mitomycin C.
Okay, here I would like to mention its association with Muratori syndrome, as it is an important consideration when a patient is diagnosed with sebaceous cell carcinoma. It is basically an autosomal dominant disorder of sebaceous tumors associated with gastrointestinal, endometrial, and urological tumors without any predisposing factors. And the sebaceous tumors associated with Muratori syndrome are less aggressive and least likely to metastasize as compared to solitary involvement of sebaceous cell carcinoma in the conjunctiva. And there is almost 24% patients were diagnosed as a Muratori syndrome who were previously diagnosed as a case of sebaceous cell carcinoma. MRI head and neck of the patient showed bilateral normal globe and orbital contents with bilateral normal optic canal and optic nerve morphology, and with no significant lymphadenopathy. Patient is currently on routine follow-up, and topical mitomycin C with a concentration of 0.04% 4 times daily was given on alternate weekly cycles for 5 weeks. So total 5 cycles were given, and after 5 cycles, uh, we planned second biopsy, which was taken from palpebral and bulbar conjunctiva adjacent to the primary lesion, and sent for histopathology with proper labeling and markings of the margins with Solium 6. Basically, it was a map biopsy, as map biopsy has to be taken in the case of sebaceous cell carcinoma, including the upper and lower palpebral conch and the four areas of the bulbar conjunctiva of the both upper and lower layers. And it was negative for malignancy in the entirely submitted tissue, and it just showed conjunctival tissue hemorrhage and congested blood vessels. Okay. This is the picture of 5 cycles of after 5 cycles of mitomycin C. Okay. This is a picture of lower conjunctiva. Okay. This is the upper lid showing basically concretions and a little bit of inflammation after 5 cycles of mitomycin C, which was previously masked by inflammation post-operatively. So important points regarding this case are incidence of sebaceous cell carcinoma, its treatment options, and recurrence rate. Regarding incidence of sebaceous gland carcinoma, it is about 3.2% of eyelid malignancies and only 0.8% of eyelid tumors, and rarely presents without lid involvement. Here, the lid was not involved, only the conjunctiva was involved. That was this was a rare presentation, actually rarest presentation. Okay. The treatment options is surgical excision is the mainstay of treatment and obtaining map biopsies of conjunctiva. And if conjunctival epithelial involvement is there, so treatment options are cryotherapy of the tumor bed with the double freeze thaw technique, and topical mitomycin C 0.04%, topical fluorouracil 1%, with 4 to 5 cycles or 3 to 4 cycles alternatively. Radiation therapy in very selected cases due to its hazardous complications, and orbital exenteration according to the extent of the lesion if it invades the orbit, and specifically literature mentioned about the involvement of the bulbar conjunctiva. If it is involved, then plan about surgical exenteration. And there is a reference of this condition is mentioned in American Academy edition 22 and 23 and American Journal of Ophthalmology. Here is the case report one of the same case, which was isolated primary sebaceous gland carcinoma of the bulbar conjunctiva, which was reported in American Journal of Ophthalmology in September 2022. On the right side, there is a gross view of the sebaceous carcinoma, which involves the inferior limbus and infranasal quadrant of the cornea. And on the left side, there is a slit limb photograph after the 9 months of the case. Patient was on 5-fluorouracil 5%. Patient was followed after 1 month, then after 6 months, and then after 9 months. There was no associated inflammation or any signs of recurrence at the 6 months. After 9 months, there was a concerning, they concerned about the pseudopterygium or possible early recurrence as growth was extending inferiorly onto the cornea. Last minute. Here is the histopathologic report. Okay. Case report 2, which was reported in Oman Journal of Ophthalmology. Same case, sebaceous gland carcinoma of the bulbar conjunctiva. This is the gross appearance of tumor mass at inferior limbus of the left eye encroaching the cornea and hanging over the lower eyelid, but eyelid was not involved. Okay. The conclusion is that sebaceous gland carcinoma is basically a lid tumor, but solitary bulbar conjunctival involvement is possible and should be kept as differentials in patients. And routine post-operative monitoring is mandatory due to its highest local recurrence rate, that is 30 to 35%, and it is mentioned in American Journal of Ophthalmology, September 22. Thank you. Thank you. Yes. No, sir, there was no corneal cycle. Cornea was totally clear. We gave almost 5 cycles of mitomycin for like 4 times per day, 1 week, then 1 week gap, and for continuous for 5 days. Yeah, so if I may, idea was, if one gap between cycles for the system to cover and the cornea and our target was to start, tumors that have high variety that they do not have low. So that was the objective to how to reduce the toxicity of the cornea. And the point, what was the criteria? Sir, no, sir. Sir, basically, reference was mentioned in the literature that they gave 3 to 4 cycles, maximum 5 cycles of mitomycin C and 5-fluorouracil. Then we discussed about the other options like infiltration or radiotherapy. Yes, sir.
This conference will now be recorded.
Thank you very much. Thank you. So if there are no questions further, we will proceed to the second case. Now, Allah subhanahu wa ta'ala made man in the best of form. Now, what happens when this natural process goes wrong, and what are the management surgical options that we can explore in these cases? The next case is going to highlight just that. So, Dr. Anita is our final year postgraduate resident. He's going to present a case of cryptophthalmos and how can we manage it with different surgical techniques. Dr. Anita.
Assalamualaikum. I will be presenting a challenging case of hidden eye. 7 months old female child was brought to us in OPD with this kind of malformations of upper eyelid since birth. She is the second child of her parents. An important point in history was positive history of stillbirth of a sibling who had complete cryptophthalmos in both eyes. When she was presented to us, she was just using ointments and lubricants which were prescribed elsewhere. On general examination, child was not able to fix and follow the light, and on pediatric consultation, no other systemic anomalies were reported. And on ocular examination, as you can see in this picture, there is malformation of bilateral upper eyelid with whole of the cornea is covered by upper eyelid in right eye, and in left eye, 2 by 3rd of cornea is covered by upper eyelid. Both upper eyelids are adherent to superior aspect of globe with abnormal superior cornea. And as you can see in this picture, rudimentary lateral part of eyelid is present with shallow conjunctival sac. And on ocular examination, lower lids and cornices were normal. Interior segment details were not possible. And on B scan, there was well-formed globe with normal posterior segment in both eyes. So, on basis of these clinical findings and a positive family history of complete cryptophthalmos, we made our diagnosis of abortive cryptophthalmos, which is also known as congenital symbolophron variant. Before going towards the management and surgical reconstruction of cryptophthalmos, briefly I would like to tell what is actually cryptophthalmos. It is a group of rare congenital eyelid defects. It differs in severity. It has 3 clinical types. Number 1, complete cryptophthalmos. It is the most common type, and in complete cryptophthalmos, there is basically a complete absence of normal eyelid margin. There is just a sheet of skin extending from forehead to cheek. And in incomplete or partial cryptophthalmos, there is a sheet of skin on medial aspect of eye, but lateral eyelid structures are normal. And in third type, which is abortive cryptophthalmos and is also known as congenital symbolophron variant, which was our diagnosis as well, there is usually a well-formed globe with the abnormal superior cornix and adherent upper eyelid with superior aspect of globe. These kind of manifestations of eyelids are associated with syndromic manifestations as well. Then they are called as Fraser syndrome. Clinical findings in Fraser syndrome are umbilical hernia, laryngeal stenosis, and cutaneous syndactyly, and urogenital dysgenesis. Clinical findings are divided into major and minor criteria. 2 major and 1 minor criteria, or 1 major and 4 minor criteria should be met for the diagnosis of Fraser syndrome. We decided to go for surgical intervention for management of this case. Parents were concerned about poor visual prognosis. They already had an idea about the poor visual prognosis, and we further counseled them. So the aims of surgical reconstruction overall, and in our case as well, were to provide the adequate protection of eyeball, and to re-establish the functional eyelid with a reasonable cosmetic appearance, which was a parent's main concern as well. Before telling about the surgical steps we did for reconstruction, I would like to explain the basic principles of surgical reconstruction. If there is a small defect involving 1 by 3rd of eyelid, then we go for direct closure or lateral cantholitis. And if there is a moderate size defect measuring up to 1 by 3rd or half of the eyelid, we usually go for tensile semicircular flap. And if there are large defects involving greater than half of the eyelid, we have 2 options. Number 1 is Cutler Beard lid shearing procedure, or number 2 is Mustarde lid switch flap. In lid shearing procedures, Cutler Beard procedure is a classical lid shearing procedure, but it has some of its disadvantages. Number 1, it lacks tarsal plate, so there is instability of the upper eyelid, and there is absence of normal lid margin and lashes, and flaps should be kept for 4 to 8 weeks. So we decided to go for Mustarde lid switch flap, also known as pedicle or rotational flap. in which the flap is taken from the lower eyelid and then it is rotated at 180 degree at its hinge and then it is sutured to the upper eyelid defect. In Mustardi lid switch flap, donor flap is taken from lower eyelid. It should be having a height of 5 millimeters to have its own vascular supply. Now I will be explaining the surgical procedures and all the surgical steps we took for the Mustardi lid switch flap. Left eye was operated first. First, the upper lid, which was adherent to superior aspect of the globe, was separated, and a symbolophrectomy was done. Then amniotic membrane was placed on uh, exposed surface of cornea and in fornices. In second picture, this is amniotic membrane over exposed surface of cornea and in fornices as well. And the upper eyelid margin was made clear. And then full thickness incision was made in lower eyelid, starting lateral to the punctum, sweeping down to the inferior extremity of the lower fornix. And then it was rotated at 180 degree, and then it was sutured to the upper eyelid defect. This is a post-operative appearance of left eye. And then opening of the flap was done at 4 weeks. Ideally, it can be done at 2 weeks, but patient presented late to us. And at the same time, right eye was operated. Second picture is showing flap sutured in upper defect of right eye. Now I'm going to share a video for comparison of pre-operative and post-operative appearance of this case. As you can see, there is reasonable cosmetic appearance with good mobility of upper eyelid. And in right eye, Mustardi lid switch flap is still at its place. There is still a room for fornix reconstruction. This is in this video clip. Right eye is at first post-operative day after opening of flap. As you can see, there is still room for fornix reconstruction, which we are planning to do as a next step with buccal mucosa or anything. But we were able to achieve our surgical reconstruction outcomes up to major extent of functional eyelid and good mobility of upper eyelid with reasonable cosmetic appearance. Thank you.
Thank you very much. Excellent talk. May I ask you,
Yes, sir.
did you look for oculodigital phenomenon in this
Mhm.
ये आपको किसी जानने का ये है कि बाजू का डॉट के रेयर है लेकिन मजबूरी में आ भी सकता है तो ये जरूर देखने चाहिए हाँ आपने इसमें because they have some residual receptors in the eye but and you know all eye senses person who hasn't been restored with all functionality. They just enjoy by stimulating those photoreceptors. So they use the liquid to poke into the eyelids and stimulate, and they get satisfaction. But that, on the other hand, can lead to other problems. We need to educate the family about what the therapy is. But I was also that but it is glad to see that he has also come out of the liquid. And we can see the rest of the technology and I can congratulate first of all Sasita who can see out of the posterior segment and then Fahad Kamal and then Supriya. Supriya की तरह लेकिन वो आमतौर पे वो बिहाइंड की चीज़ रहती है I'm really glad to see all those people. So I hope it's going to go very hard. testing which has been done by your principal. You provided you an atmosphere where you can do unintimidated medical education. के लिए प्रयास करें मेरे प्रार्थना medical education. Thank you very much. So if there are no other questions, can you proceed to the next page? Thank you, Dr. Naik. Now, the next case is a very interesting case of endangered cranial disc innervation disorder and what are the management options that we have. So it is going to be presented by Dr. Robab, who is our final year postgraduate president. Dr. Robab, please.
Assalamualaikum. I am presenting the case of congenital cranial disc innervation disorder today. So, our patient XYZ, age 11 years of age, male, he is resident of Fakka Kila Khas Nankana Sahib, presenting in our OPD with the drooping of left upper eyelid and decreased vision in the left eye. This drooping of left eyelid was since birth, and it was associated with decreased vision, I already mentioned. And he also narrated downward deviation of left eye, and he can say that the movement of the left upper eyelid while eating. The rest of the history was unremarkable. There was no trauma history. He never used any spectacles. The birth history and the developmental history were unremarkable as well. It was a consanguine marriage of the parents with the 5 children, and all the siblings were healthy and alive. Personal history and drug history were also unremarkable, and he belonged to a low socioeconomic status. Now, coming towards the examination, the visual acuity of the patient in the right eye was 6/6, while in the left eye it was 6/60, and there was no improvement on the best corrective visual acuity. The slit line examination was normal, and there was only left eye ptosis. The bilateral fundi was within normal limit, and the corneal sensitivity were present. So this is the picture of the patient when he presented to us in the OPD. In the right picture, you can see the left eye ptosis, whereas there is left hypotropia as well as the mild exotropia of the left eye. So the Hirschfeld test was performed, which shows there was left hypotropia of approximately 40 degrees and the left exotropia of approximately 15 degrees. The cover test shows the left hypotropia with poor refixation. On the prism cover test, the left hypertropia of 70 prism diopter and the left exotropia of 30 prism diopter. The extraocular movement shows restriction in the elevation of the left eye across the horizontal plane. There was left elevation under action of -4 as compared to the normal eye. The ductions were equal to vergence and there was no diplopia. So these pictures are showing his extraocular movement. You can see that the patient is unable to elevate eye across the horizontal plane. The side gazes are normal as well as the down gaze. Again, to emphasize, the patient is unable to elevate the eye in the dextral elevation, in the primary gaze, and as well as in visual elevation. The total examination of the right eye was normal. In the left eye, it was lid crease was absent. The marginal reflex system 1 was -4 millimeter. MRD2 was 5. Marcus then jaw winking was positive. Levator function was of 7 millimeter. The Bell phenomena was absent. This video is showing the Marcus and jaw winking phenomena. You can appreciate the opening of the eyelid when patient opens the mouth and moves side to side. Yes, picture showing the right eye good Bell phenomena and there is absent or very poor Bell phenomena in the left eye. The general physical examination and systemic examination was unremarkable. Differential diagnosis of monoocular elevation deficit, Doyne syndrome, Brown syndrome, congenital fibrosis of extraocular muscle, progressive external ophthalmoplegia was made with the main focus on the monoocular elevation deficit. So to reach the diagnosis, we did the forced suction test. which was negative. There was no significant restriction of the inferior rectus muscle. And the active fourth generation test was positive. There was slight movement, +1 of the superior rectus as compared to the normal muscle. I'll explain these in the video. So in the four-section test, we hold the globe with the help of the condyle forceps and then move in the direction of the limitation that is superiorly. So as you can see, there is no restriction of the inferior rectus muscle. So this test actually differentiates between the mechanical restriction and the neurogenic restriction. Now the active fourth generation test, the eye is placed opposite to the limitation, and then if we ask the patient to move the eye towards the axis of the limitation, that is superiorly here, and a tug is felt against a squint hook or a corneal forceps, and it is compared with the normal eye. And this test differentiates between the complete and the partial paralysis of the eye. So diagnosis of monoocular elevation deficit was made. Our three-step treatment plan was the correction of squint, then the correction of ptosis and the Marcus and downwinking, and then the correction of the amblyopia or by side by side. So in this case, we perform modified NAP procedure. The left lateral rectus was disinserted and then attached in the recessed position, that is 6 millimeter to superior rectus insertion. The left medial rectus was disinserted, resected 5 millimeter, and then attached to the superior rectus insertion. Okay, here the globe is rotated downward and usually you can see this is superior rectus, the lateral rectus. The lateral rectus is attached 6 millimeter in the recessed position from the superior rectus insertion. And here the globe is rotated downward and laterally. So this is medial rectus and this is superior rectus. And the medial rectus is attached with the insertion of the superior rectus. Here is the second post-op picture, which is compared with the pre-op picture, and you can see that the hypertropia and exotropia are corrected. And these are the post-op picture after 2 weeks. And there is the correction of the hypertropia as well as exotropia, and you can see there's improvement in the left eye ptosis. Now we are following the patient for the next step of the surgery, that is the correction of the squint, the ptosis as well as the Marcus and downwinking, and the amblyopia therapy has been started. Thank you.
Thank you very much. Excellent talk. So, any questions you can invite? Any questions? When the eyeball is deviated laterally and down with ptosis, then you have to consider the third party in the central diagnosis. The third party, the two functioning muscles are superior, oblique, and lateral. So the eye is drawn laterally by the lateral and downwards by the superior oblique. So to bring the eye down, one strategy may be that you do sternotomy of the superior oblique, or another procedure is called Scott procedure, in which you transport the superior oblique from lateral side of the superior rectus to the medial side of the superior rectus, so that the superior oblique, instead of becoming a depressor of the eyeball, becomes an elevator. And then, if after the resection of the lateral rectus there is still abduction, then you can attach the lateral rectus to the orbital wall, so that there is no pull from the lateral wall. Similarly, the orbital wall fixation of the medial rectus can also be done if the eyeball is not rotating. So the aim our aim in paralytic squint is to align in the primary field. We are not interested in elevation or abduction. That is a bonus you can see. But the main thing we want to achieve is the primary position alignment. And I congratulate that this case has been managed very well. And in the primary position, the alignment is excellent. But I would suggest that before doing the squint surgery, do not use the word ptosis, because when doing hypotropia, you do not know whether this is ptosis or pseudosis. So once the squint is corrected, the eye is in right position, then you use the word ptosis in including of the Kudos. So excellent presentation. Well done. Thank you. Excellent point. The, आपका question है, why did you start with ambulatory therapy?
सर अभी हमने सिर्फ साइड बाय साइड स्टार्ट किया स्क्रीन के बाद
साइड बाय साइड प्रोग्राम हमारे बड़े दुख हैं जो सारे का ऑक्लोप्लास्टी और पीडियाट्रिक ऑफ्थल्मोलॉजी में स्पेशलिटी थी कि सर्जन का सिर्फ शौक ही होता है कि मैंने आँख किसी कर दी खोल दी as soon as you do this any procedure करने की देखा होगा उनका stimulus to compliance is gone. तो मैं पर्सनल प्रैक्टिस में तो ये बिल्कुल मुझे मोटिवेट करता हूँ कि पहले वो एमएलआरपीएफ थेरेपी करें कोई महीना 2 महीनों में समझ तो आए कि बाद में भी उनको वो ताकत मेंटेन करें और दूसरी ये है कि once you perform surgery then every complication and everything comes in place. फिर उन्होंने नहीं कहा कि इसको ठीक नजर आता था अब ठीक भी नजर आता है so let the parents realize that this ambulance is there and they have missed the boat और उन्होंने वो एफर्ट दी जो करनी चाहिए और आगे के लिए एटलीस्ट कुछ स्टिमुलस मिले कि वो फर्दर इसको कैरी ऑन करें एम्बुलेंस पे पूरा एक लिहाज की जरूरत है थैंक यू सर थैंक यू वेरी मच नाउ आर देयर एनी अदर क्वेश्चंस फ्रॉम द स्टेज और ओके सर ओके यस क्वेश्चन पर हम क्या सीखते हैं
सर एक तो कॉस्मेटिक करेक्शन एंड सेक्सी नेम सर डॉक्टर रुबाब सर एम सर एक तो कॉस्मेटिक करेक्शन सेकंड द विजन थोड़ी अगर बेहतर हो सकती है सर वो पेशेंट कंसर्न ये था कि विजन सर हमारा मकसद ही है to improve the vision of the patient so that they can
देखो बात सुनो
जी सर
आपने इसको ठीक किया
जी सर
आपके ख्याल में हर एक पोजीशन ऑफ केस में वो स्ट्रेट होगा नहीं होगा
हाँ
तो सिंपल
जी सर
सारी पोजीशन केस में सीधा नहीं होगा ठीक है कभी नहीं होगा
जी
फिर ऑलवेज है डिप्लोपिया so I want to get diplopia so I want to
जी सर
ये कहते हैं कॉस्मेटिक यू आर नॉट कंसर्न अबाउट द डॉक्टर रीजन डॉक्टर जी हम इसको बना ही नहीं सकते तो बना सकते हैं फास्ट ठीक है सारी उम्र की इसको डिप्लोपिया के तो मुसीबत पहले जिंदा था मुसीबत लड़ता है so we are not aiming for a phenomenon so probably we are not concerned about it हम लाइक ओके क्यों खराब कर रहे हो हमने लोगों के साथ तो फिर वो सुंदर जी तो ब्रश करके चल रहा है सारा कुछ कर रहा है आपने उसकी नींद को अच्छा कर दिया तो वो तो फिर मुसीबत हो गई
ठीक है
जी एम्प्लॉयर की बात में डॉक्टर जी ने then employer की एक्सपेक्टेशन को दिया बाद इसमें तो क्यों लेना चाहते हैं डिप्लोपिया देने के लिए तो डोंट वांट टू गिव डिप्लोपिया so all you are doing for cosmetic reasons तो आपने इस प्रोसेस को देखना
जी सर
प्राइमरी पोजीशन में cosmetic पोजीशन
ओके थैंक यू
thank you very much now just as Professor Zahid Saab said that Sim can't get enough of the victor. So our next two cases are vitrectomy cases. And first we're going to present a case with a series of time bombs. So I would like to invite Professor Salman Ahmed, who is our manager resident, to present the case. Professor Salman. Bismillahirrahmanirrahim. My name is Dr. Salman, and I am a resident of ophthalmology of SIM. The topic of my presentation is multiple time bombs in a single body. So one time bomb is basically enough to destroy a building. So just imagine if you have a series of time bombs in a body, so it can happen anytime. So it is just the kind of case we managed here at SEM. The patient presented to us in OPD. She is a 19 years old female, a resident of Begumpura, student by profession, and her presenting complaint was decreased in the right eye for 1 year. She had a gradual painless central loss of vision, which was extending to the periphery for 1 year, and it was associated with floaters. No medical and past physical history, and she was wearing glasses for the last 2 years. Now, this is the important part. She had a positive family history that her father and paternal uncle died of brain tumor, and the grandfather died of abdominal tumor. She was a student of BSc, unmarried from a middle class family. The general physical examination was unremarkable. Now, on the ocular examination, she had a visual acuity of hand movement in the right eye, which didn't improve with pinhole, and she was RAPD positive. The left eye had a gain of 618, which improved with pinhole, and the rest of the extraocular motility, the lid, the cornea, everything was clear and normal. The lens was clear. The intraocular pressure in the right eye was 10 and 12 millimeter of mercury in the left eye. Now, here is a color fundus photograph of the right eye. We can see a fibrovascular band overlying the disc in the juxtapapillary area, which is basically raising that area with a taut posterior hyaloid. And here we can see a localized exudative detachment with a demarcating line, which is caused by leaky vessels from these retinal hemangiomas, which she was having. Here is a circular, rounded reddish lesion between an artery and a visual. This is a capillary hemangioma. Here is the cerebral fundus photograph of the left eye. We can see a taut posterior hyaloid with increase in vascular tauticity of the inferior quadrant more marked than the superior quadrant, and the dilated vessels are basically feeding that tumor in the periphery, and we can see a fibrous band overlying the disc. Here we can see a little bit of more temporal extent of that, and we can see that. On FSA, basically we confirmed it, and overlying this area we saw leakage which was diffuse in nature, and in serial FFAs we saw it increasing in the pattern. This is an FFA of the left eye, and we saw associated leakage from this area, and a lot of diffuse leakage in the inferior quadrant. And here are two signs. Basically, can somebody tell me what are these signs? Because a typical in such a case, these are light bulbs. Basically, these are basically, if you see the associated part in the color fundus photograph, you can't see any lesion. So subtle lesions basically light up on FFA like this. So we can confirm it. On the OCT of the left eye, basically there was a taut posterior hyaloid. So there are corrugations and elevations on the retina. We perform investigations just to see, because in some cases it is associated with polycythemia, and there was none here. We also did LFTs and RFTs, they were also not. Now this is the positive part. She had a small meningioma in the spinal cord and no abdominal tumor detected. So the diagnostic criteria for von Hippel-Lindau syndrome is that if you have a positive family history, then you just need one retinal hemangioma, one retinal brain hemangioblastoma, or any visceral lesion to confirm your diagnosis of von Hippel-Lindau syndrome. But if you don't have any family history, you should have two or more retinal hemangiomas, two or more brain hemangiomas, or single retinal or a brain hemangioma with a visceral to diagnose it as a case of von Hippel-Lindau syndrome. So we made a diagnosis of bilateral retinal capillary hemangiomas with exudative retinal detachment in the right eye. We started her with oral steroids, which is a bit controversial, but just to reduce some inflammation and some exudation. And there was argon laser photocoagulation was performed in the right and left eye, and she was referred to a neurosurgeon, a general surgeon, and a physician and oncologist.
Now here are some pictures of after the treatment of laser photocoagulation. You can clearly see that sorry, you can clearly see that the vascular component of the lesion has decreased in size, but it has caused a lot of exudation associated with it, and the fractional component has increased a bit. This is what happens when you do laser. And this is a picture of the left eye, and you can see a lot of fibrous component. The vascular component has almost vanished. It has decreased a lot, but it has associated with fractions caused on the retina. So for those fractions, we need to do a pars plana vitrectomy. So most of the cases, if it is near to the disc, we avoid that. But in such a case, if it's in the periphery, so right eye, we did a pars plana vitrectomy with oil, and left eye we observed because the lesion was very intratemporal. So we were just observing that because it was not involving the macula. So the main part in such a case is that we need to screen for the relative because it is a disease that presents in an autosomal dominant pattern. Already she had a family history of death in from the father's side. So all the siblings were screened. Detailed examinations were performed with fundoscopy and FFA. Here, the sibling workup, you can see very subtle lesions with associated slight hyperfluorescence. And here you can see some more fluorescence. And these siblings were also we did laser photocoagulation. Here are some pictures uh, after the laser photocoagulation. So, what is the recommended protocol of these patients? What do we need to do to avoid those future time bombs which can present later in her life? We need to do an annual physical examination, an annual comprehensive fundal examination. We should do an MRI of the brain and spinal cord every 3 years, up till she is 50 years old, and every 5 years thereafter. And an annual renal ultrasound to detect for any renal tumors and pheochromocytomas with MRIs and CT scans. And for pheochromocytoma, we need to do a 24-hour urine collection of the vinyl Mandelic acid. And the screening protocol for the risk for the relatives is basically almost the same with a bit different. That there should be annual physical examination, annual fundus examination from the age of 5 years, since they are 5 years old child, and to see for any tumors, MRI of the brain and spinal cord every 3 years up till they are 50 years, up till the age of 60 years, and this rest is almost the same. So what is basically von Hippel-Lindau syndrome? It is basically an autosomal dominant condition which is characterized by these tumors, distal cysts and benign tumors in multiple organs, and they have the subsequent potential for malignant change. In most of the cases, they are retinal hemangiomas, CNS hemangioblastomas, pheochromocytomas, renal tumors, and some others, lung cysts, pancreatic cysts, epididymal cysts. And what is the pathophysiology behind that? So how does a cell basically detect hypoxia? It detects it through a protein called the VHL protein. The VHL protein basically detects hypoxia. So that is the protein which is mutated in this case. It has two domains, the alpha and the beta domain. And basically what happens is that the VHL protein binds to the hypoxia inducing factor to basically destroy it. This is basically the factor that is causing all of the problems over here. And basically, the beta protein fails to bind to it because of a mutant alpha domain. So that leads to increase in VEGF and production of the retinal and CNS hemangioblastomas. It also increases the gluten pathway and increases the upregulation of the gluten receptors to increase glucose into the cells. They are basically feeding those tumor cells and transforming growth factor alpha to increase that. And the prognosis in such cases is highly variable because of the complications, and ophthalmic treatment is really able to preserve good vision. And basically, the cause of death in such cases is these intracranial and renal tumors. And the median age at death in patients who have VHL is 45 to 50 years. Thank you very much. I would invite Khalid to have some words. Just that retinal tumors are very, very challenging, very challenging because it leads to executive cancer and if you treat them, you never see, like I said,
Move on. Okay. Now, our last case of today is a very beautiful display of how balance of forces are to be maintained in the field of retina because retina does not allow you, does not give you a second chance. And this is depicted excellently in the cases of advanced diabetic eye disease, where we perform bimanual vitrectomy, which is by a SIM technique. So I would like to call Dr. Asad for today's presentation. Dr. Asad is our final year resident.
Assalamu alaikum. My patient is 47 years old male who is resident of Faisalabad and presented with progressive decrease in VN in both eyes, left more than the right for the past 1 year, and complaints of floaters for the last few weeks, more in the left eye than in the right eye. VN in right eye was progressively decreasing and it was painless and was associated with red spots in front of the right eye. And VN in the left eye, there was a sudden painless loss of VN in the left eye with the um history of floaters. Patient was given 3 intravitreal antivascular endothelial growth factors in the right eye and 5 in the left eye. The patient was using topical NSAIDs in both eyes. Regarding past medical history, the patient is a known case of type 2 diabetes mellitus for the last 15 years and hypertension for the last 20 years. Regarding surgical history, the patient has his appendicectomy done at 21 years ago, and it's been 21 years of age, and he has his wrist fractured 7 years back. Patient has no known drug allergies, and he is using oral antihypertensive and hypoglycemic. Patient belongs to a middle class family. There are total 5 family members, and patient is non-smoker and non-alcoholic. Regarding general physical examination, it was unremarkable except the blood pressure was 150 by 95 millimeters of mercury. On ocular examination, the anterior segment examination, visual acuity was 6 by 60 in the right eye and hand movement in the left eye. There was bilateral nuclear sclerosis and procedure of capsular cataract, and rest of the anterior segment examination was unremarkable. This is a fundus photograph of the right of the patient showing sectional fibrovascular band starting from the disc and along the vascular arcade, and they are causing fractional retinal detachment and involving the posterior pole. This is a fundus photograph of the left eye of the patient. There is diffuse vitreous haze and it is obscuring the retinal details. On B-scan, on optical coherence tomography, there were corrugated inner retinal surfaces and there was disorganization of inner retinal layers and their retinal folds. This is the B-scan of the right eye of the patient showing fractional retinal detachment. This is the B-scan of the left eye of the patient showing diffuse vitreous hemorrhage and a complete PVD. So the treatment plan of the right eye was P44/4 sparse planar vitrectomy with bimanual technique, chandelier-assisted bimanual technique for tabletop detachment. In the left eye, intravitreal bevacizumab injections were given, and patient was put under observation for the next 3 months. And if the vitreous hemorrhage did not resolve, then we planned for the sparse planar vitrectomy with capsular cataract with cataract extraction. Principle of bimanual vitrectomy. In diabetic vitrectomy, we do vitreorexis to remove the traction on the from the peripheral retina, and there is multi-layered vitreous schisis. So we stain the vitreous and remove the vitreous layers one by one. This is a video of bimanual vitrectomy done by our worthy professor, Dr. Khalid Bahid. In this video, we can see that we are using chandelier light, and with one hand we are raising the peg of the fibrovascular tissue with the engraftment forceps, and with the other hand we are using vertical and horizontal scissors, and we enter into the plane of fractional retinal detachment to relieve the traction that can cause iatrogenic breaks. And after that, delamination of epiretinal membrane is done and removed by vitrectomy. This was the picture of the right of the patient before the surgery, and this is the post-op picture of the patient after bimanual vitrectomy. Thank you.
Very much. An excellent presentation, Dr. Asad. I would like to add just a few points for the residents over here. That a diabetic vitrectomy is very different from a normal vitrectomy in a lot of ways. Starting with when you enter in a diabetic vitrectomy, you have to do a vitrectomy so that you can, so you have to do a vitrectomy so that you break the connection with the central vitreous from the peripheral traction. So because in a diabetic retina, it's very easy to produce hydrogen spray. And the reason for that is because a diabetic retina is a ischemic retina. So because of the lack of peptide, it's a very thin fiber retina. The second point is that in vitreous, the vitreous of the diabetic patient is, one of the layers, there is vitreous type. So even if you do a vitrectomy and you think that, okay, now I'm going to take up the urine, but you still find that there is a layer of your highlighted that. So in those cases, triamcinolone gives us a very handy, technique to stain the vitreous and then remove it. And lastly, yeah, in diabetics, you have to go in before a cover of anti-VEGF because these lesions, when they deep, tend to be a lot. And for a few, final remarks, I would like to call the final thing. Beautiful duration. Because I think this is very focused for of the this comment from Virgin from all of Lahore, where diabetics as sometimes diabetics we consider very different. And when I started doing this as a fellow, I always found the requirement of being able to put hands during the session without, lighting up the retina with one hand and with the other hand, using both of the this as well of the 23 27 camera, you can actually reduce easily around the globe. So I, as the second day, I take on board, I do on the exercise, I do on the exercise, just to pick up the vaccine nothing. If the more thing is that if you apply the wrong thing, one wrong vector and you produce an accident space. And that's actually a very, very bad disease. In that all direct reference is already where compromised blood supply.
the take home message is that no matter how advanced the technology may be, if you have the right level of support, you can certainly rescue a lot of people.
Thank you very much.
Any comments?
सबको बुलाने के दौरान हम अच्छा लोग मैं चेक करना चाहता था कि इतनी यही है यहाँ पे कि और जगहों में प्रेजेंटेशन करनी होती थी वहाँ पे मैं जो हैंडल करता आई थिंक काफी the unsung hero of knowledge. We should all give him this क्योंकि वो बंदा जो पीछे काम कर रहा होता है और मैं अच्छी जोग्राफी और साइंस मैं रिक्वेस्ट करूंगा कि सबको कहें जो ये रिपोर्ट हैं जो और एक्शन इन सबको पब्लिश करें कि एशिया में आप साइंस करें जब तक कि इतना रिपोर्ट आ जाए जर्नल ऑफ स्पेस रिपोर्ट अगर और जगहों पे नहीं होती तो वो जर्नल ही स्पेस रिपोर्ट I think the original practice of definitely role लेकिन बिल्कुल साफ है कि इतना हाई क्वालिटी की आगे प्रोजेक्टर है कि वो इंग्लिश मदद से बहुत अच्छा है तो हमारा ऑडिटोरियम है हमारा जो ऑडिटोरियम है आई थिंक थिंक फॉलो करते साहब चीजों को इन्होंने बहुत ज़्यादा फोकस किया है ऑडिटोरियम को इम्प्रूव करने के लिए वन ऑफ द थिंग्स ऑब्वियसली हमारा जो प्रोजेक्ट है बहुत
Thank you very much, sir. Now, without any further delay, I would like to invite Dr. Hamid and myself for a very nice talk on, just a flavor of medical education because he's not only, my supervisor, my teacher, but, and sort of inspiration for me in the field of medical education. So, teachers of teachers, sir, thanks. Bismillahirrahmanirrahim. Professor Farooq Gupta, our principal, Mr. Khalid Musa, Professor Asad Saab, as well as Vice Mark, so many luminaries, the student perspective, Professor Imran Saab, Brigadier Saab, Mark, and students. I think I'll just run through what it's a difficult topic और मैं लंच के दरमियान बस मैं ही रुकावट So let's talk of the work-based assessment. I would like to dedicate my talk to the noblest soul that has ever come across in my life. I was just talking to साहब ने कहा कि आपने तो मॉडल में यहाँ कितना देर गुजारी है तो मैंने कहा 5 साल प्रोफेसर वाकिफ के साथ एज असिस्टेंट that was and then later on. So I dedicate my talk to it. So there are 3 training models. I'll just run through because एक apprenticeship based model है अब छोटा उस्ताद और छोटा और फिर process based model है which is an outcome of the industrial revolution treadmill concept के जनवरी 2000 में आप दाखिला और जनवरी 2004 में आप 4 साल में ओपीडी में थिएटर में हर जगह रोटेट करेंगे तो आप खुद ही कॉम्पिटेंट होंगे और सीख लेंगे एंड द थर्ड कॉन्सेप्ट इज कॉम्पिटेंसी बेस्ड आप पहले फैसला करें कि उसको क्या क्या चीजें आनी चाहिए एट द टाइम ऑफ ग्रेजुएशन राइट सो कॉम्पिटेंसी इज an ability to do something well and so you have to be very knowledgeable skillful and the right attitude. And now the world is talking of entrustable professional activities, which Professor Farooq would come up very forcefully as an advocate. Competence individual है, मैं बहुत काबिल, लेकिन क्या मैं काम भी कर सकता हूँ? और that has also been certified and evaluated during the training program. And assessment is the jewel in the crown of the medical education and supervisors. आप इम्तिहान की वजह से पाए लेकिन क्या कोई ऐसा सिस्टम हो सकता है जिसमें इम्तिहान जरा बैकग्राउंड में so this is the middle pyramid. Medical educations are very fond of triangles and shapes. So this is 4 layers. आप किसी चीज को knows of, and that
The first 2 layers can be easily assessed with aptitude, and the next 2 layers are a challenge, especially with the soft one. आप जिंदगी में खुद रियल लाइफ में पेशेंट्स को हैंडल कैसे करेंगे, ऑपरेट कैसे करेंगे, डायग्नोज कैसे करेंगे, कैसे नहीं करेंगे. So that is the area where we are talking of workplace. So in order to take up the challenge, the workplace definition hands on. During this meeting, in January, Dr. Farooq when he was planning to meeting with Professor Carl Goldman, पूरे इंटरनेशनल वर्ल्ड तो इनके साथ हमने जितने भी करिकुलम डॉक्यूमेंट्स पॉलिसी को पहले किसी किसी हम पहले क्लास में हमारे पास है डॉक्यूमेंट्स और आगे so very important to have only with me and young mother. We with him to our college documents. Okay? So the whole idea is summative article exam, intermediate model exam, we talk about the very work with. What I am going to do during the training program, that is what is formative assessment is all about. Assessment comes from the word
done it. So you're so satisfied कि मेरे trainees, मुझे आज की meeting में हमजा का comment. I would always cherish that. I would always love to recall that we did something and we handed over the baton to the next generation. Next. And with this passion,
Passion के बराबर कुछ नहीं होता. And these pictures are what Khalid does every year. So for the last couple of years, and then you see the plot, you see it is passion personified. So ladies and gentlemen, it's been a pleasure. It's a very difficult area to share, but this is the future. And this is where we belong as trainers, as trainees, and as training programs. Thank you very much. Thank you very much, sir. And just on this note, I would like to add on that when I entered my presidency, on my first day of presidency, Mr. Hamid Mahmood Shah gave me ADC of medical education, and his words were that my job is to make you a good teacher. Ophthalmologist you can become. So, so if you would like to ask anything because we have a teacher. So the next presentation is going to be by the national speaker, Dr. Ahmed Salam. और learning कैसे बेहतर हो सकता है. तो medical education के लिए आपको ophthalmology के साथ-साथ so just for the motivation of the younger police, मैंने MCPS एक्टिव किया, जिसमें वो हमारे सेक्शन होते हैं और उसके बाद एग्जाम होता है, फिर आर्टिकल पब्लिश करना होता है, फिर जाके डिप्लोमा मिलता है. और फिर उसकी बेसिस पे मुझे मास्टर ऑफ मेडिकल एजुकेशन फ्रॉम दिल्ली मैंने वहाँ पे एडमिशन लिया और वो कोर्स कंप्लीट किया. तो इस तरह आप MCPS के बाद FRCS भी करते हैं, तो कई दोनों सिस्टम्स को आप एक्सप्लोर करें, इसमें कोई बात है. उसी तरह आइए करें कि आप पहले मेडिकल एजुकेशन यहाँ पे करें और फिर कोई तो तीन इंटरनेशनल यूनिवर्सिटी पूरा मेडिकल एजुकेशन का एक हॉलैंड में, कनाडा में और तो मैं
now we're going to continue with our international speaker.
Organisms. Risk factors, we're all aware of risk factors of endogenous endophthalmitis, but I want you to think about it like there need to be a source of getting the fungal inside the blood. Maybe the patient would be immunosuppressed, maybe not, like intravenous drug use. Can a patient who's immunosuppressed only without any recent history of intravenous drug use or indwelling catheters or surgery contract fungal infection? We've seen this very rarely, and probably there is a source of the getting the fungal infection inside the body that is missed. So regarding the pathophysiology, it comes from the choroid into the retina, and those sections, the pathology on the left and the macro section on the right, shows it very nicely as it butts inside the eye from the choroid, where it's flat region, raised choroidal lesion, then into the retina, and then into the vitreous. Let me show you some pictures here regarding the course of fungal infection. The antechamber can be mild inflammation, sometimes a severe with white reaction. Usually the eye is not too inflamed. There's an early case here of fungal infection. You can see in the color picture there's a very small lesion. You can see more on the autofluorescence. You can see as well areas of blood as well because of the systemic effect of the candida infection. But you can see clearly the macular lesion, which is rebudding from the choroid inside the retina very nicely on the OCT scan as in figure C. Here you can see the fungal lesion into the retina and budding inside, especially the picture on the right side. You can see the string of pears here, or the cotton ball-like lesions on the left side. And similar here, you can see a fungating lesion or a budding lesion on the disc. String pearls and the budding lesions, very suggestive of candida infection. This is the picture of the previous patient. As inflammation settles down, you can see the lesion becoming more consolidated. You can see the vitreous opacities. You can see an inferior lesion, which was not seen before. That's after treatment with systemic and intravitreal treatment. There's a different patient who had renal surgery, then decreased vision, then he got these lesions, and here after starting treatment, the lesions become consolidating. I can see one of them on the left side budding inside the vitreous cavity. That's the same patient we discussed in the last slide. And the other eye, you can see the lesions are healing and getting vascularization and scarring around them. They can become so vascular that actually you can even give them anti-VEGF before vitrectomy to diminish the vascularity. Because of enhanced vascularity of the lesions, they can go on to develop tractional retinal detachment. And this is the appearance of tractional retinal detachment following fungal infection. So this is a nice table which answers an important question, difference between fungal and bacterial endogenous endophthalmitis, and the fungal is more gradual. If you also have raised lesions and budding lesions or choroidal mass, that's more likely a fungal infection, while in the string of pearls, while the bacterial infection usually have more diffuse, and subretinal abscess is more common with bacterial infection as compared to fungal infection. So diagnosis, so first it's a diagnosis of suspicion, and clinical diagnosis, you want to support that. If you culture the organism from blood or from urine, you can also do antechamber tap or vitreous tap or vitrectomy with vitreous tap. In that paper here quoted, they said showed 90%, but usually it's in the range of 60%. PCR have been tried to improve the success, but the results are not very good. Now there is a test called 2B, which can be done on blood and vitreous, and it seems to be getting more response and a higher yield. As for the treatment, I would like you to remember systemic treatment, very important. Voriconazole or fluconazole, much better than amphotericin B. If the lesions are flat in the outer choroid, that's more than enough. If lesions are raised or you're getting endophthalmitis, then you need now to add intravitreal treatment. Voriconazole is much better than amphotericin B, but more expensive and has more broad spectrum. But amphotericin B still can work for intravitreal injection. And there's a nice slide that shows the susceptibility for amphotericin, fluconazole, and voriconazole. And you'll find that fluconazole is better than amphotericin B, and voriconazole is the best. But the drug is more expensive and is more toxic as compared to fluconazole, particularly on the liver. As for intravitreal treatment, again, same thing was shown that voriconazole is more has more wide spectrum of coverage. An important question here, what about the role of vitrectomy? The role of vitrectomy for management of complications is very well established, and there is no doubt that this is very helpful. For example, persistent vitreous opacities after treatment, epiretinal membrane, retinal detachment, whether it's traction or rhegmatogenous. But the question is, does vitrectomy improve the vision? So if you do vitrectomy for cases of fungal endophthalmitis early on, does that lead to visual improvement? Two studies, one of them we did, and another study from Bera et al. That showed actually there's no difference in the final visual acuity if you do vitrectomy or not. However, we found that actually it decreases the risk of retinal detachment later on. The problem is it's a difficult surgery, and sometimes those patients are very sick to do vitrectomy for, so it's good to know what's the role of vitrectomy for vision. Personally, I treat the patient with systemic and intravitreal treatment if needed, and then vitrectomy later on for fungal endophthalmitis. This is a case of presumed fungal endophthalmitis in a patient with a history of intravenous drug. The patient was treated with systemic and intravitreal voriconazole, and a vitreous tap biopsy came back as negative. The patient responded to treatment with some decrease in the vitreous haze from 4+ to about 3+, but he was left also with macular and peripapillary traction from the central presumed fungal lesion. Vitrectomy surgery was indicated to clear the vitreous opacities and also to relieve the macular traction. We are now about 3 to 4 weeks post presentation and initiation of treatment. This is the anterior segment appearance at the time of vitrectomy.
Posterior spinal key was dissected using a viscoelastic and blunt dissection.
Vitrectomy was started under air to get a large vitreous biopsy that was sent for microbiology. Next, infusion was switched to BSS and core vitrectomy was completed. The hyaloid was partially separated, so it was not difficult to complete the hyaloid separation with the vitreous cutter. Now attention is given to the posterior pole lesion to try to remove the traction of the nerve and the macula. The granuloma is connected to the peripapillary retina with thin membranes, so here I'm peeling these membranes off to be able to reflect the lesion. Now the lesion is getting loose and I'm peeling it off the optic nerve. So like in adherent diabetic membranes, it's safe to peel over the optic nerve to initiate the dissection, but once you go over the retina, you need to cut and delaminate rather than peel. And the same applies here. So once I went over the retina, now I'm delaminating the lesion using a pair of 25G scissors. Here I'm performing a posterior capsulorhexis, starting with a side poured blade and completing it with a pair of Utrata forceps to deliver the lesion through the anterior segment and out of the eye. Now back to the posterior segment to grasp the lesion, bring it anteriorly through the capsulorhexis over the iris and then out of the eye. This is the histopathology of the lesion, showing lots of inflammation and necrosis. With GMS stain, we could actually isolate candida lesions. And this is the appearance of the eye after surgery with 20/40 vision with a contact lens. Thank you so much for watching.
Fungal endocrinitis is a very challenging complication to deal with. Luckily, we don't see much of it in our country. Uh, the common, the more common form is endogenous. And this usually is patients who are or previously in ICU or who are immunologically, have some sort of immunological issues or serious illness, and we get involved with endocrinitis because of fungus. Uh, the reason for the disease being so aggressive in them is that they look at us. So they're so ill that if you answer the regular response or that the fungus has got. So the one that we see because of the post-operative level, luckily we don't see much of fungus as the cause of that endocrinitis. However, fungus in the eye is also very dangerous because it is not easy to see. And also, since we have limited amount that we can use, and the medication is expensive too. So, it's a systemic treatment. There should be at least 40 and when you start it, and not easily available. The one that we normally use is what is on a door and LCD. Nowadays, we have not toxicity. So, it's not an idea. It's very badly for the patient to develop from the endocrinitis. The way we deal with it is try to give intelligence, intra-visual, and fungal that we do most of the time.
Because these eyes are very hot and we need to cool them down initially by giving intravitreal antifungals. And then vitrectomy again, we always leave oil in these patients. Oil acts as an antifungal. It stops the growth of the fungi within the posterior segment. So the take-home message is diagnose a patient with fungal endophthalmitis early. The video that we
We find
and we hardly receive, resources to this institute. Rather than work, this view of fungus, and the British cavity is full of pus, and so it's not an easy condition to deal with. But the answer only is the tracking. You can't sit on these patients. You have to go, really hard on them.
Thank you very much, sir. Now, without any further delay, I would like to ask Dr. Khalid Sir to kindly announce the results of the presentations today.
All the presentations were excellent, and it was very difficult to decide first, second, and third because there was hardly any difference. I congratulate all the speakers, presenters, and their supervisors. Actually, all the cases were worth reporting in the literature. So they were unique, and this shows the interest the supervisors have made in the making of the presentations. Well done, excellent. So certificates for the presenters, Dr. Salman, please come here. Sir. So, certificate to Dr. Salman. Next is Dr. Muhammad Asad. So, and the third position goes to Dr. Faisal. So, Dr. Ubeza. Second position goes to Dr. Ubeza. Dr. Ramab. First position, Dr. Ramab. Professor Hamid Mahmood Saab, thank you very much, sir. And he will be also supervising the session in the Bhutan meeting coming on the 7th, 8th, 9th July. So we will have a session of WDC here also. we are thankful to Helix Pharma for supporting the event. Thank you very much. Okay, so we will present a bouquet to the host, Professor Khalid Raisa from OSP. Excellent event. Khalid Raisa wants to give bouquet to chief guest. Guest of honor, although Nadeem Bhatt साहब थोड़े से लेट हैं, but he's still with us. So thank you very much. Next OSP meeting will be in LRPT on 15th July, and I will request Qualitative Hub to say anything.
Yes, sir. Yes.
Thank you very much. First of all, I really thank Professor Khalid Waheed for the invitation. Our chief guest, Professor Nadeem Hafiz Barsa, our former principal and our teacher, Professor Hamid Barsa, and all the dignitaries, my friend, Professor Wayne. Me and Wayne worked together at LGH for last 6 years. I think that's one of the best times of my life. We had such a friendship and brotherhood. So I really enjoyed his company, and I think, inshallah, the way he's going forward, it would be a great achievement, inshallah. So I want to share, because there are many residents here, I just want to share a few things with you, because I think you are our future, and it's very important for us to inspire you and teach you what is right and what is wrong, where you should go. Now, three things are very important. Now, attending such meetings, there is a significance of meetings. Now, you all know that the healthcare is actually teamwork, right? So there are interdisciplinary meetings and there are interdisciplinary meetings. So we have now interdisciplinary measures like you are having, maybe in combination with other people who are orthoplastic, with retinal surgeons. This is interdisciplinary. And then interdisciplinary between different specialties, because healthcare is so complex. Without teams, you cannot work, right? And for team, that's very important. You should understand the concept of leadership. And one of the main job of our teacher, the professors, is to not only develop the good professionals, but also good leaders. Because the healthcare is complex, our problems are unique. And as a professor, I think we should also start focusing on developing leaders. And my understanding of leadership is very simple, right? And that is, a leader is supposed to bring a change. अगर आपने चीजों को सिर्फ कि आज खबर अच्छी जानी चाहिए, किसी को यहाँ से खबर निकलनी चाहिए, right? So this might be good management, but it's never leadership, right? So we have to develop that courage. We have to develop vision. जब फाइनली MBBS में तो मैं मुझे अभी तक सर ने मुझसे पूछा कि आपके टीचर को, तो कुछ टीचर का नाम तो थोड़ा कंफ्यूज था, लेकिन जो पहला सवाल उन्होंने मुझसे पूछा था वो अभी तक मुझे याद। उन्होंने कहा फारूक, व्हाट इज द डिफरेंस बिटवीन आई साइट एंड विजन? And for the first minute, as you imagine a fourth year, final year students, for the first minute, I was just on the back foot. Maybe I still do not know what is the difference between eyesight and vision. But there's one vision I've been introduced to. I did my MBA recently, and that concept is very, very clear in my mind. What is the vision? Every leader is distinguished because he has a vision. Because vision is the one which sets the direction. Vision is the one which sets the purpose, right? और उसकी ऐसी मिसाइल है कि एक साइन पोस्ट है, एक नॉर्थ स्टार है, और एक लीडर के एक अच्छा यार, और उसको अच्छी तरह डिस्क्राइब करे और आपको एक अच्छा यार, we have to go to this direction. It gives you the purpose. My request to all the professors and big names sitting here is, please start investing in developing the leadership. Because what we are lacking, we are probably developing other sort of leaders who have seen that the shortest way to get something is to protest, to block, and then creating a bad image of the profession. We are paying the price for that. Wherever meeting I sit with, I have to face that bombardment of questions. Are you producing such lot? Are these the future leaders? Are these the products? तो थोड़ी सी मुझे भी शर्म आ जाती है कि मैं probably अपना रोल सही तरह प्ले नहीं कर. We have to develop the courage to tell them what is right. This is very, very important. For the postgraduates sitting here, that you're all in the process of learning skills. And one of the things which I want to recommend to you is a book by Anders Ericsson called The Peak, right? And Anders Ericsson has basically studied the expertise, why you become great athletes, why you become great sportsmen, right? Surgeons are one of the best athletes on the planet, right? So how can you become good surgeons and develop good skills? So the concept is of deliberate leadership, deliberate practice. And what is that deliberate practice? In simple definition is that random practice. अगर आप 3 साल की किसी चीज में स्किल में डेवलप करते रहे, you cannot become an expert, right? Random practice. तो ऐसा मतलब कि मैंने कैटरेक्ट के 10,000 ऑपरेशन कर लिए, it will not make you an expert at highest level, right? An expert would be कि जो अपनी skills को deconstruct करे, small steps, वो देखे what is my weak side. So supposedly you're trying to learn tennis. So in tennis, you thought that my backhand is weak. So you pick your backhand, this is my weak area, and select a proper coach, right? See, you have to have a cognitive knowledge. Select a proper coach, okay? See me doing the backhand and give me a feedback. That comes the role of a coaching. So the other thing which you need to understand is the difference between mentorship and coaching, because our professors are not only leaders, but they are mentors and coach. And you have to see when is my role as a coach and when is my role as a mentor, right? So backhand, and you're practicing. So this means you have to have a focused practice in the presence of a coach, and then you go back and reflect. How am I going? What was my practice? क्या चीज मुझे ठीक करनी चाहिए? क्या चीज मैंने ठीक नहीं की? What is my goal for the next day or the next few days? This is the way you develop an expertise. So please remember the concept of deliberate practice. The last thing I want you basically to remember, especially the PGR sitting here, you need to understand the difference between knowing and learning. Anybody can share? You know, understand the difference between knowing and learning? Anyone? So knowing just acquisition of information or knowledge. If it does not bring a change in you, then it will never become a learning. So learning means change, which is basically because of the acquisition of knowledge, skills, or attitude. So that change, think of that change. Medical schools and medical hospitals are here to bring that change, which is essential. ये डिग्रियां पकड़ाने से आपके नहीं आएगी. Change जब तक आपने नहीं है. What the society demands? Highly professional doctors. और डॉक्टर्स की मैं 3 C's हमेशा याद रखता हूँ. वो अपने आप को भी बताता हूँ, बाकियों को बता रहा हूँ कि आपको 3 C's याद रखनी चाहिए. You have to be compassionate. You have to have competence. So you should be called competent. And number 3, communication skills. ये 3 C's just remember for the rest of life. I thank Professor Moeen and Professor and everyone, and especially Khalid Saab, for giving me the opportunity. I think SIMS is open for all the educational activities. You will always find SIMS, and we are so proud of our team. Recently, we managed GIG Operations I, and I think he's a hero. But I got so much of appreciation from everywhere that made me proud. And all my professors are actually heroes. I believe in horizontal leadership. Everyone is a leader, and इसकी वजह से हमारा नाम भी बन जाता है. Thank you very much, sir. Thank you very much.
Thank you very much, Professor Farooq Afzal, for a wonderful speech. He is a great speaker. We've been in LGH for a long time together, and I learned so much from him. I learn from him every day. The next day he talks and speaks at any meeting. OSP Lahore is a very vibrant ophthalmic organization, and this has been built on the shoulder of giants like Professor Nadeem Hafiz Bhatt, Professor Hamid Mahmood Bhatt, Professor Asad Aslam Khan, Professor Mia Muhammad Shafiq. These have been the past presidents and general secretary of the societies, and they have laid the foundation for this whole framework that we have monthly clinical meetings, and we've got ever-growing ophthalmologists in our society, in the Lahore Ophthalmic Society, and we are pleased that over our tenure, we've been able to increase the academic exposure to the residents with this international speakers speaking during this session. And the second thing is having international meetings. We've had the opportunity for the Afro-Asian Council of Ophthalmology meeting. I think that it won't be fair not to mention Professor Nadeem Hafiz Bhatt, who was instrumental in bringing the meeting over here, but it was managed very effectively, and we had 60 to 70 speakers over here for the meeting. And this year we have another international meeting, the Asia Pacific Ocular Trauma Society meeting, along with the Ophthalmic Society meeting, and we hope to have a big show for that as well. It is always a pleasure to be here at SIMS, and Professor Khalid Mahmood always sort of gets a very nice show over here, along with Professor Khaja Mohsin. Thank you very much. And Professor Inzar Bhatt is basically from here, but he is working very hard with us as King Edward, and we are very proud of him over there, and he silently leads in a very exemplary way. And we're very pleased to have Professor Raza Ali Shah back at King Edward. And Professor Hamad is also back at Allama Iqbal on the very keen interest of his principal, Professor Nadeem Hafiz Bhatt. Although we didn't want him to go, but still we had to sort of accept our request from the past president of Ophthalmic Society. Thank you very much, everyone coming. It won't be fair without saying thank you to Helix for sponsoring this event, and we'd like to increase our audience every time you come here. Please do come and attend the clinical meeting, give your views, and increase your knowledge, and sort of it will increase social networking with other colleagues as well. Thank you very much, all of you over here sitting in the meeting.
Thank you very much, sir. Now, I would like to invite you all for lunch. Lunch is ready, and I want to give pause of any delay.